Hello, everyone. Today's guest is Dr. Liss. Dr. Liss is founder and CEO of Physical Medicine Rehab, located in New Jersey and New York area. He owns multiple locations. So Dr. Liss, tell me about your clinic. How long ago did you start your first location, and what was the specialty of the clinic?
We started our practice in 1986, and we opened our first office in 1987 here in Englewood, New Jersey, with two doctors and two physical therapists and one physical therapy assistant. Mm-hmm. And it probably was another 5 or 10 years before we opened our second location up in Rockland County. And eventually we've opened 5 different offices in 5 locations. Wow. 3 in New Jersey, 1 up in Rockland, 1 in Riverdale in the Bronx.
Very impressive. So far you have 5 locations at this point, right?
Yeah.
Do you have the same partners that you had when you started your first clinic, or things have changed?
Well, things have evolved a little bit. The original senior partner retired a couple of years ago. And the second partner to join ended up going off on her own. Her husband's an orthopedic surgeon, and there was kind of mixed affinity, I'd say. So things at some point didn't work out. And then the next person to join us is my current partner, and that's Dr. Jeff Pavel.
Got it. And population, so being rehab doctor and providing physical occupational therapy, any other providers besides pain medicine and physical rehab do you guys offer?
Yeah, no, we're a fairly unique practice, and we always have been, even from day one when we opened up. Our intent and our goal was to be multidisciplinary and try to be as comprehensive as we could. So we opened up with doctors and therapists. As physiatrists, of course, we've spent most of our lives trying to help patients avoid surgery if they could.
Sure.
Literature has borne us out really well. When we first opened our practice, the rule was if you had a meniscus, whether you were 10 years old or 90 and you had a torn meniscus, surgery had to be done. If you were diagnosed with lumbar spinal stenosis, it didn't matter what your age was, surgery had to be done. The literature has borne out that there's really a good reason to try non-operative measures first. Having said that, of course, if the patient is an appropriate surgical candidate, then they should do surgery, but surgery shouldn't be 80% of what you do. It should be 10 or 20% at the most. So even on day one, when we opened, we had physical therapists. Shortly after, we brought on an occupational therapist as well. We have an occupational therapist in almost every office. At this point, 4 of the 5 offices have OT as well. Mm-hmm. And our PTs really have gone beyond, so that we've got PTs who really are certified in treating benign positional vertigo. We've got PTs who are specialized in dealing with pelvic floor or with sacroiliac. Sure. Back pain of pregnancy. We've got a certified hand therapist in Englewood who can treat the more complicated musculoskeletal patients. Then we've got 2 general OTs who can treat the neurological and the more general OT population. And we've always had a very collaborative approach, which most offices don't have. Most offices, you've got a therapist, you've got a doctor someplace else. Patients get sent to one or the other. They may share that patient at some point, but they don't exactly know what they're doing. They're talking and working past each other.
Right. So you guys are able to collaborate. You guys are able to speak about the patient. It allows you to provide better care this way by having that kind of communication throughout the week, throughout the month. So Dr. Liss, when did you realize you want to go into private practice instead of treating patients in the hospital? At what point, how much experience did you have when you started?
Well, that's a good question. So, I finished my residency in 1983, and initially I did work 100% at the local hospital, Englewood Hospital, I also was on staff up at Good Samaritan in Rockland, and I went to a couple of, in those days they were called nursing home rehab units. Now they're called subacute, and they've developed their own whole culture. So these places were, I guess, in a way ahead of the time, because they realized that there were patients who would be either not accepted or discharged from acute rehab places like Kessler and Helen Hayes and Rusk before they really completed their rehab needs, and still need additional rehab, and could still eventually end up getting home and in a much better functional status. So I did a little bit. I was running all over the place my first couple of years. And you're younger than me, I'm going to say, so you don't know that in 1987, when I came out of my residency in 1983, there were less than 2,000 physiatrists in America who were board certified. And in New Jersey, there were probably 100, maybe 150. And so in Bergen County here, there might have been 4 other physiatrists. The other part that I guess worked in my favor was that this was like post the 60s. People were starting to do marathons. Exercise was coming into people's lives. Wellness was becoming a big issue. None of that stuff. Medicine was always kind of like you put out fires. It was never thought about in the same way. And that worked to the benefit of physiatrists coming out, being approached preferentially for the people who were wise enough and educated enough to know that they should come to us and not go, let's say, to a spine surgeon first. We became the allopathic alternative to surgeons. Let's say, people always had the option to be alternative and go to a chiropractor, right? Or somehow figure out a way to get the primary care doctor to go straight to the therapist. But if they wanted a multidisciplinary approach with somebody who specializes in aches and pains, then they found their way to us. So we got busy, and that's why we stepped out of the hospital. We got into a situation where the hospital couldn't accommodate our patients in therapy without a 4 to 6 week waiting list. So I'd have somebody walk in, unable to walk across the room because of severe sciatica, and the chief of physical therapy would tell me, well, we can get them in like 6 weeks from now. I was like, no. So then we just opened our own office, hired our own therapists.
So it's a supply demand issue. So there's not enough.
Yeah, probably. Mainly, yeah.
Clinics there. So they say physiatrist is the specialist that's not responsible for a specific body part. It's a doctor, a specialist that's responsible for the whole body. So it's, a lot of people have an issue understanding, the concept of physiatry and what physiatry is. So since you opened up, how has physiatry evolved, in your opinion?
Well, it's certainly more mainstream. When we first opened, people didn't even know what we were. Even to this day, people will say, so you're a podiatrist, or so you're a psychiatrist. And then I have to explain, and then they, well, so then what do you do? And then because of what you said, because I don't focus like on the kidney or the heart or the skin, I try to explain what we do. We're not about a noun. I mean, or the noun is function. It's not a body part.
Right, exactly. Exactly.
So it's,
Dr. Liss, so do you remember how much your initial investment was when you opened up your first location?
No, it would probably be a joke number if I could remember, but no, I don't.
Sure, that's fine. And how big was the office space the first space that you rented?
Our first office space was probably maybe 3,000 or 4,000 square feet, something like that. I would say probably 1,500 to 2,000 square feet for the doctor space, and maybe a bit more for the therapies, but maybe 4,000, 4,500. Therapy, obviously, when you have physical therapy space, it's space luxurious. You need to have room for, especially in the age of COVID, you need a lot of space. But
yes,
even before the age of COVID.
Yes, absolutely. And now that you guys have multiple clinics, when you start a location, what kind of factors do you guys look at when opening up a location?
Well, we've always prided ourselves on having a very mom and pop feel, even though, we're kind of like corporate, but we're really not, and patients know that. So I need to have people at my front desk who both pick up the phones and greet people, who really they're not just secretaries. They actually care about the patients. They know the patients know them. So from the first moment, people feel as if someone knows what their problem is. And I mean, I always say, and patients say to me, even before I got back to you, Doc, I was 30% better. Just from the TLC, right. They got up at the front. And then that needs to be carried through to my, physical and occupational therapy aides and my medical assistants and the doctors. So even though we're pain docs, we're not like, to use the expression, we're not needle jockeys. I think we all sleep better at night, but we are not driving Maseratis because we're not injecting everything that moves. We inject a very small percent of our patients, and we really think about who needs it, and for whom it may not be worth it, and who could get better if they're just a bit more patient. I think the key for me when we open a new office is to have that collaboration right at the moment you open, so that therapists feel very comfortable, even though at the end of the day, the buck stops with the doctor. And in the case of malpractice or whatever, if the case of the patient not feeling better, then they'll blame the doctor. They may not remember the therapist's name, but in my practice, they do remember the therapist's name. They will come back and ask for the specific therapist, and the therapist feels totally comfortable saying to me, honestly, I don't think this is pure sciatica. I think there's a sacroiliac component. Or, I just actually, you're an OT. I just had one of my OTs say to me, I think you're missing the tendon part of this. This is not pure joint. And I love that because I want to keep learning. I don't know everything. And they're seeing things, they're approaching things in a similar but different way than I am. And in the course of treating or trying things, they're going to see things that I won't see. And it's exactly that difference that gets the patient to a better place ultimately.
Yeah, it's interesting you mentioned that's right. So therapists usually spends more time with the patient because they see them consistently 2 or 3 times a week. And it's the I guess that's the one way you guys stand out, because he gets to see you on weekly or daily basis and able to, I guess, bring to your attention certain things that maybe. Yeah,
right. No, and that's amazing. And then the therapist will come back to me and say, this person really needs a muscle relaxant. Or they need a trigger point injection. I can't get this done myself. Or, I'm really bothered because no matter what I do, I mean, I give you a very short story, is that 4 years ago, because it doesn't happen too often, I had a patient and I was trying to make the case that this was kind of more of a muscular or a joint-related back problem, but it was all axial back, no radiation of pain. And after 2 sessions, a therapist came to me, and it was a pretty new therapist, but they already felt empowered and said, something doesn't jive. The mechanical things I'm doing don't really reproduce the pain. Long story short, the person had pancreatic cancer. I might have missed that for an additional month or 2 if the therapist didn't have good antennas and feel very free to come right back to me and have my ears in 10 seconds.
Wow, that's a great story. Yeah, that's amazing. Sometimes just being able to come, and speak to a doctor and figuring out that, there's something not right mechanically, like you said, that, so not always, again, you see patients for, just once, every whatever amount of months, and then therapist works with that patient, 2, 3 times a week, gives them that ability to see some, discrepancies sometimes. That's great. I mean, I like the concept of physical therapy with physiatrists within the same clinic. It's a great concept. Doc, leads me to my next question. What's your best referral source when, with patients? Is it other specialists, other doctors, hospitals, or is it word of mouth? And, do you guys look at these things?
I think these days more word of mouth, friends, relatives, coworkers. We have a very broad group of doctors, allied specialists, neurologists, spine surgeons, orthopedic surgeons, rheumatologists, who all want to send people our way. We encourage them to send people to our therapists directly, and we encourage our therapists to have the independence and the charisma, call it what you want, the personality, the bedside manner, to have direct relationships and not to feel as if they're somehow, constrained in some fashion. So we have we have a lot of doctors who appreciate that our therapists, more than any, are really used to working with doctors and willing to collaborate. Any of the stupid, ridiculous, needless political stuff that goes on between doctors and therapists doesn't exist here. And that this is a safe zone. You know, they can send the patient to the therapist, and the therapist doesn't get to decide they know better, blah, blah, without some communication back and forth. So we have probably 20-30% of the patients who come in here never see any of our doctors, and in a couple of the other offices, it could be as much as 50% of the patients who are coming to the therapist.
But do you track that data? Do you track where the patient came from? Is that something that you look at on a monthly or quarterly basis?
We track it. We're not, you know, it can be tricky to track, and I'll tell you why. Because sometimes the patient walks in with a script from somebody, and the doctor themselves doesn't even know what they want.
I see.
Like I've had patients walk in with a prescription from a doctor. The patient starts doing therapy, and a week later, the doctor calls me and says, "So what did you think?" I'm like, "I don't know that patient. Let me look them up." It's like, "Well, I sent the patient to you." And I'm like, "You send the patient to me?" And then I look, and they wrote a therapy script. And I'm happy to see that patient. So that's and sometimes it goes the other way. Sometimes it seems kind of apparent that they want our opinion, and then I butted my nose in it, and it's like, "What are you doing involved?" I sent the patient to therapy.
Sure.
So that's one of the many problems of being a physiatrist is that people still don't quite understand where we fit in always.
Right. And then again, the same concept with physical therapy. I have a lot of doctors that don't get the concept of physical therapy, working with a whole body, not just back pain or old pain.
I had a patient once who was a caricaturist. That's what they did for a profession. They drew cartoons.
Sure.
And they do this great cartoon where the physiatrist was labeled on their sweatshirt, and he had a whip in his hand, and he was whipping the therapist, and the therapist was shaped like a human walker. And the patient was clutching this walker, essentially clutching the therapist. And the point is, the physiatrist was just viewed as kind of this taskmaster. The therapist was just viewed as this like dumb, like mechanical, you know.
That's a great picture. I could just see it. Was it a patient of yours?
Patient of mine drew that, yeah.
Wow. All right. So, Doc, in terms of marketing, do you guys spend any money on marketing?
We spend some. We're more disorganized than we should be.
Got it. Okay. And so, how many hours of work do you week? How many hours a week do you work? I'm sorry.
Well, I mean, I'm the CEO, so how many clinical hours? I do 4 days of clinical hours, and a couple of those are late days, meaning that they start at 8 or 8:30 and end at 6:30 or 7. A couple of those days end more like 4 or 5, and then I leave the 5th day for administrative stuff, interviewing, human resource stuff. You know, these days lots of COVID talk.
You work definitely more than 40 hours a week, right?
Yeah.
And with COVID, how has your clinic changed in terms of, you know, seeing patients? Are you guys offering telemedicine visits for physical therapy and physiatry?
Yeah.
Or like,
well, about 100 days ago, both the doctors and the therapists were literally down to 10 or 15% of our volume, literally.
Sure.
And it makes sense. You know, I mean, only the most desperate and healthiest came out. We were really good with the help of our office managers and administrative group at getting everybody, doctors and therapists, up to speed on telemedicine and on electronic therapy. I kind of chuckled to myself about e-therapy when they first talked about it. But honestly, I became a believer very quickly. And even though nothing substitutes for the therapist's manual skills,
I agree with you.
Despite that, our therapists have just been incredibly creative and innovative, and they have. It's, in a way, it has been an incredible learning experience, not just for the patients, but for the therapists in being able to look through a Zoom at posture, at body mechanics, teach exercises without getting your hands on, figure out how to work on balance without being able to catch the patient if they fail.
Yes, absolutely.
Working on positioning of limbs, let's say with pinched nerves, Having people work on their shoulder range with a frozen shoulder, stuff that we always took for granted, needed hands-on. I'm not saying if these people are doing as well as they could have done, but they've done remarkably. So at this point, I would say we're probably up to maybe 40% of our volume, maybe 50%.
You're picking up.
Things are opening up now kind of exponentially here in Jersey and in New York. I hope not too quickly.
Mm-hmm.
We're still being extremely careful. We check temperature of every person who walks in. We pre-screen them on the phone to make sure they don't have symptoms. You know, no shortness of breath, no cough, you know, no low-grade fever. You know, haven't traveled. Then, you know, when they come in, we check their temp. We have had probably maybe between a half dozen and a dozen patients between the 5 offices who have reported back to us that they then subsequently tested positive.
Okay.
I self-quarantined for 4 days after that happened until I got my own test back and it was negative. My colleague who had done an EMG on that same patient had never had symptoms, never did have symptoms, but tested positive and has subsequently developed antibodies. So it's been a real ride. We've had multiple people have to take some time off but you know, because we've been so careful with contact tracing of our own staff, when we hear about somebody, we've really kept it down to a total of like 10 or 12 people in 5 offices over a 3-month period, which is pretty amazing.
Yeah, that's good. That's good.
My docs who go to the nursing homes to subacute, 4 of them had COVID.
Oh wow! Are they doing okay now?
They're all okay, thank God.
That's great, thank God. And how many people work for you
now? My wife's practicing. My wife's practicing pre-COVID. Someplace around 100, a bit more than that. Probably, I don't know. Probably, you know, not all those people are full time. So maybe you know, the equivalent of like 60, 70 full timers and 30 who are less than 30, 40 less than full time.
Definitely. Wow, that's a big organization. I mean, 100 employees. Part-time.
Well, we've got between 12 and 14 docs, depending upon how you want to count it. Half of those are pretty much outpatient, and half are inpatient. Between the 5 offices, we've got probably 25 or so therapists. You know, so then you've got all the support staff for those people, and then you got your billing department. We do not outsource billing.
Oh, that was my next question. Good thing you mentioned that. Okay.
I don't think you can outsource billing when you're in rehab.
So a lot of clients ask me, because you know, as I said, I'm a CEO of Hellenode, and people ask me all the time. Those therapists are starting out around the country. They're like, should I outsource billing or should I do it in house? And I tell them, when you're small, some people, it's a one-man show. They kind of, the front desk, they're the therapists, everything, the managers, so they don't have time for billing. So as you said, you know, sometimes they outsource it, but then once you become big enough, when you're able to hire someone, that's the best way to do it, right?
Yeah, I mean, especially in rehab these days with pre-auths and with in-network, out-of-network, and deductibles, and you know, residual balances that the insurance refused to pay or whatever, you know, your front desk is the beginning of your billing department, and you can't outsource that part of it.
Absolutely.
In many cases, the insurances are paying $60 or $69 for a therapy visit, less the copay. You can't outsource that, because if you don't collect your $20 to $60 copay, it doesn't matter what you outsource. Absolutely. You're not going to pay your rent, right?
Absolutely. So what's the average reimbursement rate for physical therapy, would you say, among your 5 clinics?
Well, you know, a number of our doctors are part of the Columbia Association of Physicians, CAP. So some of us get a higher rate, which Columbia doctors negotiated for some of the insurances. That shifts things up a bit. So we're in New Jersey. In New Jersey with Horizon, they all, you know, it's the same $60 or $69 or whatever. There are many other companies that are kind of around there, but I would say overall our average is probably 85 or something like that.
Got it.
Not great. Hard to make a living with that.
Because the reason I'm asking, the average reimbursement rate on the East Coast of the United States is $70 per visit, and I'm talking about 70. That's an East Coast, you know.
Right. So the only reason I think we're a bit more is because of Columbia's negotiating skills. Yeah.
Yeah, that could be another factor.
We have a different model which has helped us. Because I want to sleep well at night, so I don't want to have some high school grad taking my patients through an exercise program in the gym. So our offices, I could carry this laptop around. We don't have all of our therapy booths surrounding a big gym with the therapist peeking out through the curtain so that they can say that they did another 15-minute timed code. And they really didn't, because they're in the middle of massaging Mr. Jones in the booth there. Okay, I know that's what people do because they have no choice, and that's how they get the extra code. And Medicare looks away from it, or they don't have enough manpower to crack down on it. We have legitimate additional codes. All of my offices have a PTA running my gym. That didn't even start off purely as a financial decision. It started off because we're multidisciplinary and we have docs and therapists, we tend to get a more complicated population. Probably 30 to 50% of our patients tried therapy someplace else. And now they're coming here, and we better do something different, more collaborative, more complex, more creative. So it's important to have a therapist in the gym who's not, again, just a technician of some sort, but really a professional.
Absolutely.
And it's incredible what a difference that makes. But the byproduct of that is that for those insurances that insist on one-on-one direct communication and supervision, those people are there in the gym, running the gym, and it's a game changer. It's a game changer for the quality of the outcome.
Definitely. And do you encourage, or you mandated for your therapist to have some kind of certification, board certification or something?
Yeah, we have continuing ed for all of our therapists, and we encourage people to get certified in McKenzie, try to work on their hand certification if they're OTs, we'll learn Mulligan, go to Butler, do, the whole bit. Anything that they can do, take special courses. I have a therapist who took the course in orthotic and foot management and measurement and can mold orthotics.
Oh, wow.
and work with a lab to do that. I've got people who can work, as I said, on SI. I've got a couple of people who do craniosacral for whatever that's worth. Because there are people who really do want it,
Yeah, absolutely.
So you have to be, if you're a therapist, you've got to be eclectic, because there's no right answer. There are many possible right answers.
Definitely. You're right. I agree with you on this one. And I'm going to ask you some number questions. So what EMR system do you guys use within your clinic?
A Prima.
EMR, medical record system.
Yeah, well, our software system's a Prima.
Prima.
A Prima. A-P-R-I-M-A, a Prima.
Got it. And do you guys track a cancellation rate for patients?
Yeah.
Do you know what would it be?
It's different for doctors than therapists.
Right.
And we also, we have a pretty proactive front desk. It's better in some offices than others. So let's say talking about now, if a patient's canceling, we may flip it to a telemedicine. So then it doesn't end up being a cancel.
Right.
People who are afraid to come in can still do something. But let's say going back to the pre-COVID, so I know industry standard, I think, is like 10, 11%, something like that.
Yeah, even sometimes 20. But yeah, they say a good cancellation rate is under 10%.
Yeah, so I think in most of our offices, we're generally under 10%. Now, we're in New York and New Jersey. This winter, our best winter, BC, before COVID, we were having our absolute best winter. We had no snow. We had a snowstorm over Thanksgiving weekend. It melted by the next day. We never had snow. We had amazing numbers. But of course, when you're in the New York, New Jersey area, you can have Hurricane Sandy. You could have a 10-foot blizzard. You could have downed power lines in the summer. You're susceptible to, to everything.
Or you could have COVID. Yeah, that's.
Or you could have COVID. Could have COVID.
And Dr. Liss, so what are some important reports do you guys run on a monthly basis for your clinic?
Well, some things we run weekly. We run a weekly therapy report to look at volume, to look at number of evaluations. We try to see how many visits per evaluation patients are doing. We want to both track that to make sure we're staying kind of within, industry standard, call it what you want.
Definitely.
But at the same time that we're not having people walk in, not feel that they're getting any value, and end up leaving after 2 sessions. So So we track that.
The conversion rate, okay.
We also track how often when the patient has seen the doctor and they make it to the front desk, how many sessions do they schedule? Because we found that if the patient walks up there and schedules 2 or 3 sessions, they're more likely to get, whatever got them into the problem in the first place, it will kick in, human nature. So if the patient schedules, 5 to 10 sessions, their whole course, A, they'll get the times they want, so they're more likely to stay with the appointments. B, now they've got a real plan. They know what they signed up for. And C, it helps both the therapist and them and the doctor to take a look back and say, okay, how are you doing based upon what? Otherwise, if I see a patient after a month and I said, please go twice a week at least, right? And so I'm expecting like 8 sessions, and now they came in, they added 3 sessions, and now they tell me, well, I'm only 10% better. It's a very easy conversation.
Yeah. So it's actually it's a great concept where you actually could track amount of sessions when you see it, when you personally see a patient and they tell you, yeah, I finished physical therapy, it didn't help me. Then you look at their visits and you'll say, oh, it's only 3 visits you completed. When if you were to go to a doctor outside of physical therapy clinic, then you wouldn't be able to tell how many visits they actually completed. They could have said, oh yeah, I completed 10.
Right.
Okay, so that's interesting.
It also allows us to give feedback doctor by doctor and therapist by therapist.
Sure.
The therapist not retaining their patients. That's a pretty rare problem, I have to say. The doctors not being, so we found that the stupidest thing works. The doctor walking the patient up to the therapist, that the front desk person, the patient and the doctor are all on the same page. Everybody knows what's expected. That's a home run. Whereas if the doctor says to the patient, schedule twice a week for 4 weeks, the patient ends up with 4 sessions.
Right. Makes sense.
Something gets lost in translation.
Definitely. Doc, and what is your long-term goal for your clinic? I should say your company, because you have multiple.
Yeah, I understand. I mean, I'm not, by my nature, I'm not that corporate. My goal is to help lots and lots of people. I've made a satisfactory, better than satisfactory, a good living over my life. I've had a wonderful life so far. Hope to have lots more of it with God's help. And I want the therapists to feel that they're advancing their careers, that they're learning every day and going home feeling happy, that the doctors are, and that the patients are as well. I want it to be a win-win-win. I think if it's a win-win-win, you end up making a good living somehow.
Absolutely.
And everybody ends up happy and prosperous enough.
Definitely. Doc, I will thank you for your time today. It was really informative for me. I'm hoping it was very informative for our listeners. You have a really interesting concept. I really like the fact that you guys have, all-in-one kind of clinic, doctors in it, and it seems like you guys have a great clinic. I will post your website below, within the link below. And what is the website, by the way, if people want to check out your clinic?
rehabmed.net.
rehabmed.net. And again, thank you so much for your time. It was a pleasure.
My pleasure.
We'll be in touch. I'm going to